Okay, good morning, everyone, and welcome to this Friday's Grand Rounds. It is a difficult task to introduce this morning's speaker, Dr. Krieger, because when he's asked to introduce speakers at Grand Rounds, he always finds the smartest, funniest, most witty ways to do that. So I'm not going to try to amount to how he does it. But I do want to tell you a little bit about Eric. Eric is, of course, a professor of medicine here at the Division of Cardiology at the University of Washington. He was a resident at Mount Sinai and then came back here to do his fellowship in cardiology. He preceded me, I think, by 3 or 4 years at the Boston Adult Congenital Heart Disease program where he did his ACHD fellowship. Since 2016, he's the director of the Adult Congenital Heart Disease Fellowship Program here. And since 2019, he's the director of the entire ACHD program. I want to say that Eric is a true giant in the world of congenital heart disease and contemporary adult congenital heart disease in the United States and internationally. He's an active member at the ACC chapter of ACHD. And he is a member of the Board Examination Course Review Committee. He's the editor of the ACHD section of the ACC SAP. He was an active member of the writing committee of the 2019 AHA-ACC Valvular Heart Disease Guidelines. And he is the immediate past chair of the Adults with Congenital Heart Disease Committee of Council on Clinical Cardiology of the AHA. He's, of course, the author of numerous publications and book chapters in congenital heart disease, including the most recent version of the adult congenital heart disease chapter in Brown-Wall's heart disease. He is an extremely popular speaker nationally and internationally. And when he takes the podium, the audience becomes usually very quiet because people are very interested in what he has to say. And he's been a visiting professor and ground round speaker at places like Stanford, the Cleveland Clinic, and MGH. To me, Eric is a dear friend and mentor. And today he's going to be speaking with us about valvular heart disease, anticoagulation, and pregnancy, and something about free lunches that made me very excited. So please join me in accepting Eric Krieger. And Eric, take it away.
My goodness, Yoni, I'm going to have to take you everywhere. Thank you. That was incredibly gracious. I don't have any disclosures relevant to this talk. So I think just to get started, it's worth spending a little time thinking about the types of patients we're going to be talking about today. So we'll begin with the hypothetical patient and her Google Images search result. It's a 28-year-old woman who was born with a bicuspid aortic valve. And she comes into your clinic and reports that she's quite active. She used to play tennis in college, but now she mostly just goes for walks and thinks she might be slowing down a little bit. You get an echo. It shows that she's got normal left ventricular systolic function and EF of 60%. She has severe aortic stenosis of her bicuspid valve with a maximum velocity of 4.8 meters per second, a mean gradient of 52 millimeters mercury. She was recently married. And of course, she asks, "Doc, is it okay for me to get pregnant?" And these kinds of patients are becoming increasingly common, not just in adult congenital heart disease clinics, but of course, cardio-obstetrics clinics, valvular heart disease clinics, structural heart disease clinics, general cardiology clinics. And a lot of this is a result of the success of pediatric cardiology and pediatric heart surgery. So it's now the expectation that pretty much all patients born with congenital heart disease are going to survive to adulthood. And they're going to do so usually in quite good health. They're going to have had normal childhoods, played sports, and expect to have normal lives and be able to do things like have kids and raise families. So we're pretty regularly going to have to make decisions about risk stratification prior to pregnancy for patients with significant residual heart disease. So what we're going to talk about today is a few things. We're going to talk about the preconception evaluation of women with aortic stenosis. We're going to talk about valve choices in women who are considering pregnancy. We're going to talk about anticoagulation for mechanical heart valves in pregnancy, and we'll spend a little bit of time on that because it's a tricky topic. And we'll talk about counseling. How is it that we provide our counseling? What impact does the words we choose have on the decisions that patients make? Because it's not something that we talk about very often. So the problem isn't that there's no options for what to do with a woman with severe aortic stenosis who wants to get pregnant. The problem is that there's a lot of choices, but each of those choices comes at a price. So if you wanted to be really conservative, make sure nothing bad ever happens, and just play it safe, you could discourage pregnancy in this woman. And that'll probably minimize her chance of having a pregnancy-related complication, although discouraging pregnancy, of course, doesn't mean patients won't become pregnant. But you may have a pretty unhappy patient. I mean, the decision to become pregnant is a major one, and taking away someone's ability to start a family or discouraging it has major ramifications. If instead what you want to do is get sort of 5-star ratings on your Press Ganey survey and have patients leave with a high level of satisfaction, you can say, no problem, go ahead, get pregnant, we'll take care of you, everything will be fine. But you may be exposing that woman to more risk. You could try to take care of the issue prior to conception by doing a preconception bioprosthetic aortic valve replacement, which may do a good job of getting her through pregnancy, but it's going to predispose her to valve degeneration. And as we'll talk about in a few minutes, maybe even valve-related complications during pregnancy. If you wanted valve longevity to be better, you could put in a preconception mechanical valve because those valves last for decades typically. But of course, that exposes the woman to all the thrombotic risks and the teratogenic effects of the anticoagulants. And increasingly, you might recommend a preconception Ross procedure, which we're starting to think is actually a quite good solution for many of these women. But what you really need to have is a woman with the right anatomy. You need to have a center with the right experience, and critically a surgeon with genuine expertise in doing the Ross. So there's a lot of options out there, but each of them comes with a cost. So what is the right choice for a woman like this? Well, we've known for decades now, probably more than half a century, that cardiac output and stroke volume go up during pregnancy. So here are two tables on the left that show the stroke volume over the course of pregnancy on the top and cardiac output on the bottom. Weeks of gestation is the x-axis. And what you can see is that they rise steadily during the first trimester and then plateau and remain elevated throughout pregnancy. And as we all know, of course, valvular gradients are a product not just of the stenosis, but the stenosis and the flow. So as the flow goes up, the gradient goes up. So when they looked at this in one study, they looked at aortic valve gradients over the course of pregnancy. Between the first trimester and the second trimester, aortic stenosis valve gradients go up by about 50%. So a woman who's starting out with a valve gradient of about 20-25 millimeters mercury may end up with a mean gradient of 40 or 45 millimeters mercury. And this might be tolerated perfectly well during pregnancy, but not all patients have a ventricle that's able to overcome that. There's some patients who may have somewhat of a vulnerable ventricle, and you may decompensate heart failure, ventricular dysfunction with that increase in gradient. So it's not surprising to think that aortic stenosis probably exposes the mother, and as we'll see, the fetus to risk during pregnancy. It's sort of an intuitive concept. But relying on intuition is not always a great way to practice medicine. Thankfully, we have some risk scores which identify maternal characteristics that predict adverse maternal and adverse fetal outcomes during pregnancy. So probably the three most widely cited risk scores out there are the Zahara score, which was published in 2011. That's out of Europe. There's CARPREG and CARPREG-2 most recently. Those came from the big Toronto pregnancy group, and the World Health Organization risk classification scheme. And I'm not going to go into the scores in detail, but Zahara and CARPREG-2 are all sort of similar. They had a large cohort of women with structural heart disease, mostly congenital heart disease. And what they did is they looked at the outcomes of these women and they assigned points using multivariable linear regression to figure out which maternal characteristics predicted adverse maternal outcomes and adverse fetal outcomes. They then took those scores, they applied them to a validation cohort, showed that they work, and published in good journals. And we use those. Dr. Buber, who runs the cardio-obstetrics program, use those on a regular basis. The World Health Organization risk classification schema is a little bit different. It's not so much evidence-based as it is a consensus guideline. They just took a bunch of people like Yoni and put them in a room and said, Yoni, Karen, what do you think about a woman with PVCs? How do you think she'll do during pregnancy? And they're like, fine. And they're like, okay, risk category 1. And they said, how about tetralogy? They said, usually fine. And they said, okay, risk category 2, 3. How about Eisenmenger syndrome? Risk category 4. So it's sort of a consensus-based document based on experience and experts. And it turns out actually to work just as well, if not better, than CARPREG and Zahara. But in any case, each of these scores identify maternal aortic stenosis as a high-risk condition. So our intuition says it should be high risk. The scores show that it is high risk. But that's not quite enough information to provide counseling, because the question they're going to ask is, okay, it's high risk, but how high? So for that information, it's probably best to go to something called the ROPAC registry. The ROPAC is the European Registry on Pregnancy and Cardiac Disease. And it was started by the European Society of Cardiology, but it's certainly a worldwide endeavor. It's a prospective global registry of pregnant women with structural or congenital heart disease, and it's fantastic. Since 2007, they've enrolled over 5,700 pregnancies in 138 centers in 60 countries around the world, including from high-income countries, but also a lot of women from low and middle-income countries as well. And because it's a prospective registry, it avoids a lot of the recall bias, the reporting bias, the publication bias that you see with these retrospective studies, people's case report, people's case series at 3 studies. So it really provides, I think, the most robust information we have on pregnancy outcomes with all different kinds of heart conditions. So back in 2016 in JACC, they published their outcomes on women with aortic stenosis. And it was a nice paper. They found 96 women with moderate or severe aortic stenosis prior to pregnancy. And 62 of them only had moderate aortic stenosis. They had a peak gradient of 48 millimeters mercury, but they included 34 women with severe AS. And these women's severe AS was really severe AS. The peak gradient averaged 89 millimeters mercury. So, bad aortic stenosis. Most of them were New York Heart Association functional class 1 or 2, which matches what we might see in the clinic. And they had, for the most part, preserved systolic function. So when you go to the top line results of the paper, they were quite encouraging. So what you have is you have 3 columns here, all the patients on the left, moderate aortic stenosis in the middle, and severe aortic stenosis in the right. When they looked at maternal mortality, there was no maternal mortality in the entire cohort, 0, 0, 0. That was good news. But when you looked at the maternal adverse event rates, they weren't trivial. So for all aortic stenosis, cardiac admission was 21%, heart failure 11%, preterm birth 21%. And when you looked at women with severe aortic stenosis, more than a third of them had a maternal cardiac admission, 18% developed heart failure, and preterm birth in 36%. They published a central illustration from this, and you've all read JACC, so these central illustrations are an opportunity to be creative and stray from your data. And I will concede that this central illustration is not really evidence-based, but I actually think it's pretty useful. Here's what they recommended. They said, if you meet a woman pre-conception and she has moderate aortic stenosis, Vmax less than 4, et cetera, she's asymptomatic and she has normal systolic function, that it's okay, quote, okay, whatever that means, for her to go ahead and get pregnant. If you meet a woman with severe aortic stenosis by all our conventional criteria and she's asymptomatic prior to advocating for pregnancy, you should make sure she has a normal ejection fraction. You should do an exercise test, make sure she's got normal exercise capacity, doesn't drop her blood pressure with exercise. Yoni would advocate for doing a VO2 max in these patients, which I'd certainly agree with. Look at biomarkers like a BNP, and if all of those are normal, she can probably become pregnant with acceptable risk. And if they're not normal, you should either discourage pregnancy or do something to the valve prior to pregnancy. And certainly if she's got severe aortic stenosis and is symptomatic, she has a class 1 indication for an AVR, so you should take care of that prior to pregnancy. If you have the opportunity to meet a woman during pregnancy who has severe aortic stenosis, here's where things get a little dicey, and I'm not sure about their figure in this case, to be honest. They say if she's symptomatic, you should use medical therapy, because we all know how effective medical therapy is for severe symptomatic aortic stenosis. So I'm not entirely sure what that means. I suspect diuretics to treat heart failure. They then say a balloon valvuloplasty, but I think increasingly we would move to TAVR for a severely symptomatic woman with severe aortic stenosis during pregnancy. And then you should do an AVR, which I think we would typically do with TAVR if it was anatomically suitable. If she's asymptomatic and has normal systolic function, and then just try to get her through the pregnancy without complication. So This paper, which was published in JACC and presented at the ESC scientific sessions, made national news to us, I suppose. You know, we all get this cardiology news shrink wrapped and sent to our desk. And the headline, the front page of it actually was ESC, zero risk of death in pregnant woman with severe aortic stenosis, which is great, which is also not true, of course. It was zero risk in that cohort of 34 women with severe aortic stenosis, okay? We know it's not true because we have ample case reports of a woman with severe aortic stenosis who died shortly after delivery. This one of a 24-year-old woman with sudden death in the third trimester. And this one from the University of Washington, maybe 15, 20 years ago, about a 23-year-old woman with severe aortic stenosis who died postpartum, Tom Easterling, Catherine Otto, and a number of other people on that paper. So we have a lot of choices, but none of them are straightforward. Well, what would we recommend for our patient? She's 28, she has severe aortic stenosis, she's asymptomatic, normal EF. So according to that flow chart, which I think is a reasonable starting point, you should do an exercise test, look at biomarkers, and if those are normal, you should put a great big green check mark on her belly. If those are abnormal, you should do something prior to pregnancy, or at least advocate for something prior to pregnancy. Any of us who do this regularly know that there is a large difference between discouraging pregnancy and preventing pregnancy. Those are not the same thing. Many times, what we say is not what causes someone to become pregnant or not to become pregnant. That's a topic for a totally different grand rounds about how this all happens. All right, so let's imagine that we decide we need to do something. She's symptomatic or her EF is down. You could recommend a preconception bioprosthetic aortic valve, which is great because it'll restore the hemodynamics and you don't need to anticoagulate during pregnancy. That's the pluses. The minuses, of course, are that valves degenerate faster in young patients. Pregnancy may accelerate valve degeneration, although that's controversial. I'm not entirely sure it's true. And if you start putting bioprosthetic aortic valves in women in their 20s, you're going to be setting these women up for repeat sternotomies. There was this great enthusiasm of, no, you won't. We can just do valve in, valve TAVR. And I think the enthusiasm for that sequential therapy is a little bit on the downslope. Bioprosthetic valves don't last that long in young women, and valve TAVRs don't necessarily last that long in young women. So we don't still think that TAVR is the primary right solution for most young patients with valvular heart disease. So here's some data just showing that valvular bioprosthetic valves last less long in young patients. The cohort in this study is older than the group that we're talking about, but it is remarkably a single center study of 12,569 bioprosthetic aortic valves in different age groups, which is a lot of aortic valves for a single center. And they showed that structural valve degeneration is accelerated in younger patients. So patients under age 60, I sort of highlighted them in orange here. You can see by about 15, 20 years, you have 30 to 50% need for valve replacement, whereas patients 60 to 80, the rate was much lower. And for patients over 80, almost none of them got a redo AVR, but I think that might be for a variety of reasons, not just that their valves didn't wear out. So preconception bioprosthetic valve may get you good pregnancy outcomes, but you're likely setting your patient up for a lifetime of repeat sternotomies. But maybe it doesn't get you perfect valve outcomes. So just last year, again in JACC, the Toronto group looked at their CarPreg registry and published their data on 101 women with 125 pregnancies who had bioprosthetic valves during pregnancy. Most of these women had congenital heart disease, so 30% had left-sided valves, 70% had right-sided valves. They'd had their valves for about 6 years prior to conception, and a quarter of them had valve dysfunction, and almost all of them were New York Heart Functional Class 1 or 2. So this is their central illustration. The top left corner of this figure is all that matters. So that is the intersection between patients with left-sided bioprosthetic valves and valve dysfunction. So left-sided bioprosthetic valves with valve dysfunction had high incidence of maternal cardiovascular events, 47%, and high incidence of adverse fetal events, 60%. whereas women with right-sided heart valves or those with normally functioning left-sided bioprosthetic heart valves did much better. The valve complications were more common, like I said, in patients with dysfunctional left-sided prosthetic heart valves, advanced maternal age, and those that had a high-risk composite Carr-Preg score, sort of a variant of the Carr-Preg score. But again, I want to highlight this, and we're going to come back to this a few times. So they reported 47% adverse maternal cardiac events. But when you break that down, there was one maternal death, which is important, but only one, no strokes, and only 2 fetal loss. And this starts to get at something that I think is very important, which is this concept of these composite endpoints that almost all of these studies have used, and how we translate those composite endpoints to patients. A patient, as we'll get to later in the talk, might hear a 47% risk of an adverse cardiac event, but if that adverse cardiac event is a transient atrial arrhythmia or the need for a few days of diuretics, that might be perfectly acceptable for someone if their priority is pregnancy and starting a family. We'll talk about that more. All right, so there's some downsides to bioprosthetic valves preconception, but they aren't a bad choice, and that is what the guidelines will recommend, as we'll show. Let's get into the mess of mechanical heart valves in pregnant women, because it is worse. So mechanical heart valves clearly put the mother and fetus at risk. Their mom is at risk for valve thrombosis, embolic complications, and hemorrhage. The fetus is at risk for miscarriage and teratogenic effects and fetal demise. Warfarin crosses the placenta, anticoagulates the fetus, and can be teratogenic, as we'll talk about. The problem is that you really need anticoagulation with mechanical heart valves at all times, but certainly during pregnancy, because pregnancy is a hypercoagulable state with increased risk of thrombosis and really poor anticoagulation options. On this table on the left, it shows the impact of pregnancy on all the different components of the clotting cascade, sometimes with tenfold changes. The net effect of this appears to be a 2-fold increase in coagulation activity and a 5-fold increase in the risk of DVT and PE, which we see clinically. So again, intuitively, we know that mechanical heart valves put the mother and fetus at risk. And again, to get a little bit more information, we can go back to that ROPAC registry, that European registry that prospectively looked at women with all sorts of heart disease. And in 2015, they published their results of mechanical heart valves in pregnancy. 212 women prospectively observed during pregnancy with mechanical heart valves. Unfortunately, they were not able to compare, or they did not compare different anticoagulation strategies in this. So what we can learn from this paper is really sort of the net risk of having a mechanical heart valve during pregnancy, and it's substantial. 23% with a cardiac hospitalization, 15% with major hemorrhage, 5% risk of valve thrombosis, and a 1.5% risk of stroke. Fetal outcomes, 16% miscarriage, 3% fetal demise, 18% preterm birth, and more than 5% with congenital anomalies, which is likely related to a combination of the teratogenic effects of warfarin, plus the fact that these moms, many of them had congenital heart disease, although many had rheumatic heart disease. Really importantly, the maternal mortality was 1.4%, which is quite high, and the major adverse event rate was 42%. So the conventional wisdom from decades of experience is that when possible, you should avoid mechanical heart valves in women planning pregnancy. But that doesn't answer the question of what you should do with a woman with a mechanical heart valve who is completely committed to pregnancy or who comes to you already pregnant, because then your job is still to find the safest anticoagulation strategy for both her and for the fetus. So the number one guiding principle of all of this is that you need uninterrupted effective anticoagulation throughout pregnancy in all women with mechanical heart valves. That's number one, it's a given. But then the question is, where do you go from there? So warfarin. Warfarin, of course, is the anticoagulant that we use for pregnancy. You guys may have just all seen the New England Journal study that just came out showing apixaban failed in onyx valves. Warfarin is the standard anticoagulant we use for mechanical heart valves because it's effective. The problem is it's teratogenic for the developing fetus. So warfarin embryopathy, just as a brief review, is most common when the fetus is exposed between the 6th and 12th weeks. Up to 10% deformity and 20% loss. It's characterized by mid-face hypoplasia and short limbs. Relatedly, you also have an anticoagulated fetus when the mom takes warfarin, even if the fetus doesn't develop warfarin embryopathy. And there's some debate as to whether there's any effective intellectual impairment with this disease. So the goal of anticoagulation during pregnancy in women with mechanical heart valves is to mitigate the risks of warfarin while still providing adequate anticoagulation. So there's sort of three strategies, and they're broken up by trimester. If you want to completely eliminate the risk of warfarin, which many doctors and women, especially in the United States, do, you can just give them a form of heparin for all 3 trimesters. Heparins are large molecules. They don't cross the placenta. They don't affect the fetus. They don't anticoagulate the fetus. So they're the safest option for the fetus. If you want to mitigate the risk of warfarin embryopathy during the first trimester, you could give some form of heparin for the first trimester and then convert to warfarin for the second or third trimester. You get rid of the risk of warfarin embryopathy, but you still have an anticoagulated fetus, but better anticoagulation for the mom. And if you want the mom to be the safest, you might give warfarin for all 3 trimesters, although that's going to increase the risk to the fetus. Just worth noting, prior to delivery, you always switch to IV heparin, so you don't deliver an anticoagulated fetus vaginally, which has a huge risk for brain bleeding, and so that you don't have a durably anticoagulated mom during the time of delivery either. So there's never been a good prospective trial of anticoagulation strategies during pregnancy, ever, and there never will be, probably, of a prospective randomized trial. So until relatively recently, sort of the most widely cited trial was this large meta-analysis that was published in the Archives of Internal Medicine in 2000. And it was a meta-analysis of 28 papers published between 1966 and 1997 of almost 1,000 women with over 1,200 pregnancies. Importantly, 50% had ball and cage valves. 66% had mitral valves. These were mostly rheumatic. And the maternal mortality in that study was 3%. And they compared these 3 approaches of anticoagulation. They looked at, on the 3 columns, maternal death, thromboembolism, and congenital anomaly. And in the 3 rows, the different anticoagulation strategies I talked about: heparin throughout, heparin for the first trimester, then warfarin, or warfarin throughout. And they found what we thought they'd find. For maternal outcomes, the worst events were with heparin for all 3 trimesters. In between was heparin for the first trimester and then warfarin for the second and third trimester. And the best maternal results were if you gave warfarin for all 3 trimesters. Of course, they find the exact opposite for fetal outcomes. Fetal outcomes are best if you give heparin for all 3 trimesters, and fetal outcomes are worst if you give warfarin for all 3 trimesters. So the take-home messages from this 2000 meta-analysis were that pregnancy is very high risk in women with mechanical heart valves, and that unfractionated heparin, which is what they used, either high-dose BID subcutaneous unfractionated heparin to a target PTT or continuous IV unfractionated heparin throughout pregnancy, has unacceptable maternal outcomes. It had 7% maternal death. And finally, warfarin is associated with poor fetal outcomes. Okay. But remember when those papers were from and who the women in it were. A lot has changed since the 1960s. They went from ball and cage valves to much more modern, less thrombogenic valves. We no longer use IV heparin in high-resource, high-income countries in the United States during pregnancy. We only use dose-adjusted, targeted, low molecular weight heparin following anti-10A peak levels. So a lot has gotten better since the 1960s. Not everything has gotten better since the 1960s, I'd advocate. We went from the Beatles to the Bieber. So when Zach was a fellow, were you a fellow, Zach? Zach was a fellow. He came up with the idea of redoing this with modern data, which no one had really done in any comprehensive way since 2000. He wanted to compare anticoagulation strategies for modern mechanical heart valves in pregnancy and describe maternal and fetal outcomes that are of interest to patients and doctors, none of this soft stuff like transient arrhythmias. He decided to go ahead and include studies that had unambiguous reporting of outcomes in pregnant women with mechanical heart valves who used one of these different anticoagulation strategies, and we were going to exclude populations that were no longer relevant to contemporary practice. We were going to exclude ball and cage valves, right-sided mechanical valves, which are extremely thrombogenic. Exclude small studies, less than 5 patients, because case reports have the ability to shift your meta-analysis through reporting bias. And we're going to exclude any papers that had been previously put into that old archives meta-analysis, and exclude anyone who is using fixed dose heparin without following anti-10A levels, because that absolutely doesn't work. So if you've ever done a meta-analysis, you do your original PubMed search, you're like, yes, 825 papers, this is great. And then we eliminated nearly 600 because they were irrelevant. We were left with 250. We excluded another 100 because they were not, they were mostly review articles. Then we had 155 articles, of which we were left with only 18 papers that met our inclusion criteria for 800 pregnancies. 800 pregnancies is still pretty good, and Zach poured over all of these and adjudicated every single pregnancy and every single pregnancy outcome in this paper. We decided to look at 4 strategies in this. First strategy is warfarin throughout. Again, everyone goes to unfractionated heparin at the time of delivery. And there had been more data that there was a big important difference in terms of fetal risk to women who took low-dose warfarin versus those who took high-dose warfarin. The teratogenicity for the fetus is dose-dependent. So we subdivided it into women who required less than or more than 5 milligrams per day to maintain therapeutic anticoagulation. We looked at women who took low-dose adjusted low molecular weight heparin throughout pregnancy. We looked at women who took low molecular weight heparin for the first trimester and then warfarin, and then unfractionated heparin for the first trimester and then warfarin. And the outcomes were things that seemed unambiguously important: maternal death, major embolic complications, and prosthetic valve failure. And we looked at spontaneous abortion, which is a really hard endpoint. And the one I'm probably least confident in this paper, because whether people report early fetal demise is so variable. But fetal death after 20 weeks seems more reliable. And then congenital defect or embryopathy. So this, again, speaking of central illustrations, was our figure, but it is the data. So the first thing is the risk to the mother with those 4 strategies that we talked about. So if you look at the risk to mother, the top are warfarin and low-dose warfarin, and the risk to mom was low in each of those. And then in each of the other strategies, low molecular weight heparin bridging to warfarin, low molecular weight heparin or IV heparin, the risk to the mom was higher, 3-fold higher. If you look at the average risk to the baby, you get, of course, once again, the opposite result. For women who took high-dose warfarin throughout pregnancy, the risk of a major adverse fetal event was 39%. It was lower with low-dose warfarin, less than half, and lowest yet with low molecular weight heparins. But if you look at the combined risk of an adverse event to either the mother or the fetus, it was pretty high with each of these anticoagulation strategies. The one where it was best was with women who were able to maintain therapeutic anticoagulation with low-dose warfarin throughout, but that's only a portion of women. And it's almost never in women with mechanical mitral valves, which require a higher INR target. So the combined risk is high throughout. We published that within a few months. The European Heart Journal published another meta-analysis that was published by, that came out of, was it Canadians? I think it was Canadians. They looked at had more inclusion criteria, more looser inclusion criteria. So they had more studies, more women, more pregnancies, but they found the same thing, that for maternal events, warfarin was safest. For fetal events, low molecular weight heparin was safest, and that the combined rate of maternal or fetal adverse outcomes was high. Warfarin safest for the mom, heparin safest for the baby. And this data just shows that low dose warfarin has less teratogenic effects than high dose warfarin. More live births, fewer teratogenic events. So you could read this and say, all right, low dose warfarin or low molecular weight heparin bridging to warfarin, that's the way to go. That's the way the guidelines came out. And I do think in many ways that is the way to go. But any of you here will be like, well, Krieger, that's not what we do here. And if you go to other big centers, you'll see that's not what they do there. If you go to Southern California, where Uri El Qaim is and has a huge population of women that he's followed with mechanical heart valves. We do not use much warfarin in the United States during pregnancy, despite the fact that the guidelines recommend it, despite the fact that the evidence shows that it's safest for mom. And I don't think we know exactly why that is. I mean, I think that the United States is a litigious society and fetal risk is high. I think that tolerance for fetal risk in the United States is lower than it is in other parts of the world, just culturally. It is used in Europe. It is used around the world, but it's not used much in the United States. And if you talk to people like Karen, like Yoni, like Zach, like our cardio OB group, like Uriel Kaim, like the folks out east, they'll say the reason low molecular weight heparin doesn't work is because people don't know how to give it. So the guidelines will say you give it, you follow peaks, you get a peak anti-10A of 0.8 to 1.2, you check it 4 hours after, you adjust it. But the folks who do this all the time will say, yeah, but people do it really badly. People do it really badly. Here's data that looks at trough rates in women with different peak rates. So the question they're asking in this slide is, all right, if you target someone with a peak of 0.8, how often are they subtherapeutic with their low molecular weight heparin? And what you see is 5 bar graphs here based on different peak anti-10A levels. And the y-axis is the percentage of time they have a subtherapeutic anti-10A. And all the way up to an anti-10A level of 1.2, patients spend half or more than half their time subtherapeutic on low molecular weight heparin. So many places will follow not just peaks, but also troughs. People think that they've discovered the magic sauce of how to give low molecular weight heparin safely that will do better than the data has suggested. It may be true, but the data still hasn't been published quite as much as any of us would have liked. So back in 2019, Catherine Otto was nice enough to invite me to join the valvular heart disease guidelines writing group to look not just at all the valvular heart disease, but I was tasked with the question of how should we be recommending anticoagulation for mechanical heart valves in pregnancy. Of course, the goal was to update the guidelines to reflect contemporary science, to eliminate suggestions for antiquated therapies like unfractionated heparin. But I also thought it was important to acknowledge that there's no perfect option and that we needed to think carefully about the patient's priorities. So here are some of the flow charts from those 2020 valve guidelines. So if you have a woman with a mechanical heart valve who's pregnant, she needs to maintain therapeutic anticoagulation with frequent monitoring during pregnancy. That's a class 1 recommendation. And then the first question you should ask if you're meeting a woman who wants to become pregnant with a mechanical heart valve is, can you do that? Can you maintain therapeutic anticoagulation with frequent monitoring during pregnancy? Because not everybody can. And if they cannot, you should counsel against pregnancy in that situation, a class 1 recommendation. But even if they can maintain therapeutic anticoagulation with frequent monitoring, we still recommend that you counsel that there's no anticoagulation strategy that is really safe for the mother and the fetus, and that you need to engage in shared decision-making. That's not quite discouraging it, but it's making sure that folks really understand they're entering into a high-risk endeavor. Next question is, can they get therapeutically anticoagulated with less than 5 milligrams of warfarin a day? If so, class 2A recommendation to continue warfarin for all 3 trimesters. We don't see that very often here, or in the US, as I said. If women really want to avoid warfarin during the first trimester, there's a 2B recommendation to use low molecular weight heparin and then warfarin for the 2nd or 3rd trimester. But if women require high dose anticoagulation, more than 5 milligrams a day, we recommend avoiding warfarin during that first trimester because of the high teratogenic effects. Recommend using low molecular weight heparin for the first trimester, warfarin for the 2nd and 3rd trimester. Or for women who really want to avoid warfarin throughout, there's a 2B recommendation can be considered to use low molecular weight heparin for all 3 trimesters. There's some data on unfractionated heparin, but it's really not relevant to the US. As I've mentioned, you stop warfarin and switch to heparin a week before delivery, and you hold anticoagulation for 4 to 6 hours at the time of delivery, and you restart postpartum. So that's sort of the recommendations that came out of the guidelines there. Which sort of brings us to the topic of the talk, which is this concept that there ain't no such thing as a free lunch, which was actually taught to me in 11th grade by my environmental science teacher. This idea that everyone said, save the planet, stop drilling, no more cars. And he said, well, what are you gonna choose penguins over people? What are you gonna do to all the folks that have jobs that depend on the things that your idealistic 11th grade mind is opposed to? You can't get something for nothing. So it's true in environmental theory, it's true in economics, it's true with technology. If you want the smartest and the lightest and thinnest phone, it's going to run out of battery. If you want a giant electric vehicle, it's going to only have 100 miles of range. You can't get something for nothing. The phrase apparently originated in these sort of gold rush boom towns where saloons would offer free lunches across from work sites, or where people were, I don't know what they did, they panned for gold or something. I don't know, I'm from New York. But they would offer these free lunches and they'd load them up with salt, and then people would come in and they'd buy beer. And lo and behold, they'd end up spending more money on beer during lunch than they would have if they just paid for their lunch on their own. To this concept of, you can't, there ain't no such thing as a free lunch. You can't get something for nothing. It's also certainly true for anticoagulation strategies in mechanical heart valves, or just how we manage high-risk pregnancy in general. Every decision we make is going to come with a trade-off. I don't know what time it is. 10? 12, perfect. So I think that, even if we know all the data about how to manage high-risk pregnancies, or all the data about how to give anticoagulation during pregnancy, that's only half the battle. Because we need to find some way to communicate this risk to the patient. And this is an area of communicating risk that I think most, at least non-invasive cardiologists, really don't spend very much time thinking about. I think the invasive cardiologists, I think surgeons, I think folks like that get pretty good at communicating risk. But most of us non-invasive people, we really don't get training in how to communicate risk effectively. Our informed consent is somewhat perfunctory. We don't really think very much about how patients perceive risk. We don't really think very much about what types of risks are acceptable to patients. And when we talk about risk, we almost exclusively talk about immediate risk. We don't talk about the long-term risks. For example, what's the long-term consequence of pregnancy in someone with a cardiomyopathy? What's the long-term risk of putting in a biologic heart valve for 25 years down the road? We think about the short-term risk. I was reading about short-term risk and I came up with this beautiful, has anyone ever heard of micromorts? Okay, so I came across micromorts. I don't think they're terribly academic, but micromort is a unit that is a 1 in a million chance of dying from something. And it turns out that each of us has about a 1 micromort risk of dying from non-natural causes on any given day. That's where it comes from. So people have made tables about relative micromort risk. So driving 333 miles is a micromort. So is flying 7,500 miles. Rock climbing is 3 micromorts. Scuba diving is 5. Yoni, running a marathon is 7. Hang gliding is only slightly more dangerous at 8. Giving birth is 120 micromorts. It's a lot. Not as bad as base jumping or commercial fishing. And climbing Mount Everest is 12,000 micromorts. It turns out that when you study how do different people perceive risk, people make all sorts of cognitive errors in terms of how we think about risk. People tend to overweight the probabilities of small risks and underweight the probabilities of large risks. And then what I think is important to our population is prior experience causes us to underestimate risk. So for example, if you've been rock climbing a bunch of times and someone asks, how dangerous is rock climbing? You're like, it's not that bad. But if you talk to someone who's never been rock climbing, they're like, that's terrifying. You could fall off the mountain. There was this nice paper that actually studied this for a number of things, but pregnancy was one of them. So you have perceived risk on the y-axis and 3 different populations that were looked at. Women who had previously given birth were the purple dots, men were the orange dots, irrelevant to this study. And women who had never given birth were the green dots. And it turns out that women who had previously given birth had a lower estimation, underestimated the risk of birth, whereas women who had never given birth had a higher perception of the risk. So another error that we make is when we talk about risks, we don't always discuss the risks that matter most to patients. And I've already mentioned that most of the studies that we looked at use these composite risks, but these aren't always the outcomes that women view as intolerable. The intolerable ones are relatively rare. The majority of events are self-limited atrial arrhythmias. Their heart failure, they classify heart failure as women who needed diuretics. I mean, we give almost all of our women diuretics postpartum because their ankles are puffy. That's not a reason to not become pregnant. Most heart failure is mild and most arrhythmias are atrial. So if you look at these three large studies and their published rates of cardiac events, 13, 16, and 10%, the maternal mortality was close to zero in all of them. The stroke risk was nearly zero in all of them. And the need for urgent surgery was quite low. And in a study of risk tolerability, we make tons of assumptions about what kind of risk people would be willing to tolerate. But it turns out patients are willing to accept much higher risks than doctors are in general. And that physicians who are patients, that's the one exception, physicians that are patients have the lowest risk tolerance of all. So what can we say to patients? Because what we say to patients is sometimes very different from what patients hear. So let's pretend this woman now has a mechanical heart valve. She's coming to you, she says, I'm pregnant, I have a mechanical heart valve, or I want to become pregnant, I have a mechanical heart valve. What are some true statements you could tell this woman? You could tell her a pregnancy for you would be high risk. I mean, I think all of us would agree with that. You could tell her the most likely outcome of a pregnancy is that both you and your baby will be fine. That is also numerically true. That's a true statement. You could also tell her you're more than 100 times more likely to die during this pregnancy than a woman without a heart condition. That is also true, but you can imagine how any of those three statements might cause a woman to make very different decisions about what to do. Patients don't always hear what we mean to say. A lot of this data comes from the legal community, who are much more motivated to study how our informed consent process actually informs patients. So most of the data here comes from law journals. Turns out that our words are incredibly imprecise. What do we mean when we say an event is rare? It turns out that patients' estimates of the meaning of rare often differs by an order of magnitude. Some people think it's 1 in 10, some people think it's 1 in 1,000. And that patient's age, that patient's background has a lot of impact here. Younger patients think rare means like really rare, like 1 in a million. And if you tell someone who's older that maybe has more medical comorbidities, hey, we got to do this procedure, complications are rare, they might think 1 in 50. Most patients we're counseling on pregnancy are young and relatively healthy. So what we mean by rare may not be what they hear by rare. Patients, and I put an asterisk here because doctors too, are misled by relative risk. So if you tell someone they're 100 times more likely to die from a pregnancy, that's not terribly helpful information. Here's a map of the United States and your probability of dying from a lightning strike. Your probability of dying from a lightning strike if you live in Florida is more than 100 times higher than your probability of dying from a lightning strike in the Pacific Northwest. I think that is one of many reasons why it's better to live in the Pacific Northwest than in Florida. But maybe not really a compelling reason, right? The relative risk is completely misleading in rare events. And then, as we've talked about, these composite endpoints are really good for powering studies, but really bad for counseling patients. Patients don't view all these risks as equivalent, and patients' preferences may not be obvious to us. So how can we improve our communication with patients? Well, we should avoid using only descriptive terms. Saying something's rare is not terribly helpful, but low risk is vague. But similarly, you have to be conscious not to dump, 52 papers on them, because patients' ability to process a lot of numerical data is limited, and what patients remember from clinic visits is relatively small. That's been studied. Try to use absolute numbers and avoid relative risks. And consider thinking about how you frame a question. There's this concept of positive framing, which can encourage high-risk choices. Hey, there's a 95% chance that everything will be fine. There's a 99% chance you won't die during this pregnancy. That's positive framing. Negative framing is, there's a 5% chance that you'll have a stroke or die during this pregnancy. That could discourage risk-taking. A balanced approach is obviously just to say both. There's a 95% chance that you won't have a major complication, but a 5% chance that you might have a stroke or death. It's a small thing, but it actually turns out to matter in terms of patients' understanding and decision-making. We don't do this very often, but visual aids can be helpful. Of 100 women just like you, 5 of them may have a stroke or die or valve thrombosis during pregnancy. So these visual aids are helpful, but I mean, we don't carry them around, so I'm not entirely sure how to incorporate them in practice. So in conclusion, the guidelines can help us direct us towards the safest strategy, but pregnancy in women with valve disease can be risky, and pregnancy in mechanical heart valves has no single best option. Just another way of saying there ain't no such thing as a free lunch, and we need to be thoughtful about how we communicate risk, and we have to think about our patients, how they understand risk, and what their priorities are, and make sure to take those into account when we provide counseling. Thank you.
The audio is spectacular. Thank you, Eric, for a wonderful, wonderful talk. So if we have questions from the audience.
Eric, thank you very much for a wonderful talk. When we're counseling patients, I find that oftentimes when we present, option A, B, and then 20 minutes later, we talk about option XZ, they're overwhelmed. How can we, what is your strategy for giving them the objective information that they need to make the decision, and also helping the patient not feel so overwhelmed with the decision, that's to them?
Yeah, I mean, I think there's some times in counseling where what you want is just someone to make the decision that they need to make, right? You go in there, someone's having a STEMI, you're going to counsel them on the risks of bleeding and complications, but basically you're there to get them to sign the form so that you can wheel them back to the cath lab. And there you just really try to keep it down nuts and bolts and, give them a chance to think it through, but you're there with a purpose in mind. I think when it comes to something like, do I want to pursue pregnancy? It is really useful to set up a clinic visit for that purpose. So we have preconception counseling part in the cardio obstetrics clinic. Patients may get all their testing so we can best understand the risk, and then they might come in for a visit with Yoni or Jill or one of us, along with the OB doc, and sit there for a 40-minute new patient visit with their partner potentially, and talk through it all. So I think making sure that they come in prepared for the conversation, they know that's the thing that they're there to discuss that day, and that that's the thing you're there to discuss that day. It's not sort of the tack on when you're, writing their discharge instructions, that, oh, hey, one more thing. So if they come in prepared, they're less likely to be overwhelmed because they've written out all their questions. So that's what I would recommend for this situation. Professor Stout.
Per usual, and thank you for reminding me why one of the things that doesn't come up in that never can is the effect of the partner or the family on that counseling. And my anecdotal experience is that the patient who is interested in pregnancy is nearly invariably more risk tolerant than the family member sitting over, whether that family member be a partner or father of a child or parent. The partner is like, wait, no, I don't lose you. Sometimes, rarely, the opposite is the case, and that is some ethical dilemmas. So, how do we think about that? How do we talk about that? And how do you just generally approach it in terms of balancing not just the risk of the patient themselves, but family members, including the kids they already have?
Yeah, I think that's absolutely true. And I think some of that comes from what I was talking about earlier, that folks who have had prior experience with a risky event are more risk tolerant, or at least perceive the risk to be lower. So you have a patient that's maybe had 3 open heart surgeries and has been through this, and having a heart condition and living with risk has been part of their lives, and they come in with potentially a new partner who's just been healthy and is a lacrosse player, and they're like, wait, what? We're talking about dying, we're talking about strokes. So you have that imbalance sometimes coming on, that it seems old hat for the patient and it seems new and scary for the partner. yeah, I mean, obviously, centering on the patient is critical, right? I mean, it is the patient's body, it's the patient's risk. You know, I think that sometimes we never try to tell folks what they should do. And this idea of, well, what would you do is always tricky because I maybe have different priorities than someone who doesn't have kids, or maybe someone wants kids more or less than I do. So it's hard to supplant your own judgment there, but you need to center on them. But if you see someone who's making a decision that just your gut says like, oh, this is just a straight up bad idea, often I will try to pivot to that. Well, not only do you need to think about your next kid, but you also need to think about being there for your current family and being around to raise a kid if you have a kid. So, you know, I wouldn't say that we ever use those things as to leverage someone in one direction or another, but you can certainly focus the conversations on those if you are worried someone's becoming too single-minded and not considering in all the other factors.
I want to expand on that a little bit. I think that another dimension that we're starting to explore these days now is the long-term effects of pregnancy with heart disease on parenthood, many years of being a parent. And this is a question that we are starting to being asked at the Cardio OB clinic. And there's some anecdotal studies that start to come out and suggest that in fact, there is a higher risk of cardiovascular disease down the road when you live, when you're pregnant with a mechanical or a bioprosthetic valve for reasons that I think that we don't fully understand. And I try to not provide this preliminary data or try to avoid it as much as I can. But these are questions that we are sometimes being asked, and I don't know that we know how to answer yet. Again, there is anecdotal study that longevity is shorter for the mother when she's pregnant with a mechanical or bioprosthetic valve.
Thanks. So it's a great talk, Eric. And you know, you go through a lot of the data of the risk during pregnancy, and it's obviously something we have a lot more data on. But when you take a patient who has pretty substantial valve disease through pregnancy and you elect not to treat it at the time, I think to me, there's a certain assumption that the patient is going to do really well for many years. After, you're really not saving them much, or you're really exposing them to a substantial risk of a fresh bioprosthetic valve or a fresh surgery in a mom going through pregnancy. But I think there's also the aspect of someone with severe valve disease who's about to enter early motherhood, which is an exhausting endeavor, and patients you may not be able to really ascertain whether or not symptoms are related to just chronic exhaustion and fatigue versus valve disease. And at that point, you're really ready to move ahead because you have to be cautious. And now you're suggesting surgery on a parent with a 6-month-old or 1.5-year-old. And I'm wondering what your approach is to severe asymptomatic aortic valve disease, knowing that they may do fine through pregnancy, but you may not really be saving them multiple years from a sternotomy, and they may be facing this decision on the other end of pregnancy, which is in many respects much more challenging. How do you handle that?
Yeah, I mean, I think it depends on trajectory a lot. You know, I mean, if you have someone who was 3 meters a second 2 years ago, then 3.5, and now it's 4.3, it's coming. You know, you might as well just take care of it. But, you know, some of these patients with congenital aortic stenosis, maybe they got balloon, they've had very stable valve disease for a number of years and fairly high functional capacity. You might get a bunch of years. So if you think someone's going to need a valve in the next year or two, and you think you can do a Ross, I would do it first. But if that's not the case, I think it's a harder decision. You just have to personalize it. Having valve surgery, having heart surgery shortly after pregnancy is not easy. I totally agree.
All right, thank you very much.
I was surprised for
I, Jamie,